and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Show Me the Records. If you have questions about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You'll need to register for this program in order to access those materials. Continuing educations have been approved for nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, continuing education credit will only be awarded for 1 year for nurses, expiring on November 30th, 2018, and 2 years for social workers, expiring on November 30th, 2019. Now, let's meet our presenter, Samaria Dunson, attorney and principal at the Dunson Group. Samaria?
Thank you so much for having me. I really appreciate the opportunity to be here today. For those of you who don't know me, I had the opportunity to work in the Office of General Counsel at the Department of Public Health for a little over 10 years. So this really feels like home being back here, and it's so good to see so many familiar faces. I'm going to jump right into our topics for today. Those topics include physician collaboration, the importance of following documentation guidelines, ways that attorneys look at dissecting medical malpractice cases, how you all might go about preventing lawsuits as you practice, some of the regulatory and licensure requirements, how to deal with high-risk patients from an attorney's perspective, as well as some patient confidentiality. And for anybody who knows me, knows that anytime I'm doing a training, if I can stick confidentiality in there about patients, I certainly want to do that. When we start to talk about physician collaboration, we want to go back to the law. And the law for that is found in the Alabama Code section, and you can see it there. And physician collaboration is deemed to be a formal relationship between one or more certified registered nurse practitioners and a physician or physicians under which these nurses may engage in advanced practice nursing. The term collaboration does not require direct on-site supervision of the activities of a certified registered nurse practitioner by the collaborating physician. However, it does require such professional oversight and direction as may be required by both the rules of the State Board of Medical Examiners and the Board of Nursing. And one of the things that I found really interesting as you studied the regulations for nurse practitioners state by state is that it appears that Alabama and Delaware seem to be the groups that you have both of those bodies providing oversight to nurse practitioners, as opposed to some of the other states who really just deem that responsibility held with the Board of Nursing. So I want to talk a little bit more about this issue of physician collaboration. It's important to understand the liability concerns as it relates to the physician who's providing the collaboration and that relationship with the nurse practitioner. In the past, what we found is because of this collaboration requirement, often when you find that the nurse practitioner is being sued because of some type of issue or an act or failure to act on behalf of a patient, you also find that the physician would also be sued as well, and it's because of this requirement of supervision. So that kind of gets you into this normal supervisor-supervisee relationship, where it's the responsibility of the supervisor to ensure that certain policies and procedures are being followed and that there's adequate training being provided. In many cases that we'll see outside in the private sector when you're looking at lawsuits, what you'll find is that you want to make sure that policies and procedures are followed, and if you can prove that that supervisor isn't ensuring that those policies and procedures are being followed, then you have more liability on that supervisor. So for physicians who practice and they have nurse practitioners that they're collaborating with, they want to make sure that in all cases that the policies and procedures are being followed, and when they're not, they want to make sure that they're reviewed and that those individuals are retrained, because there's too much liability for the physician or for the supervisor if the individuals working for them are not following those policies and procedures. And so that's just like in any other supervisor relationship. As it relates to medical record documentation, as you all may know quite well, with medical record documentation, it chronicles the pertinent facts, findings and observations about an individual's health history, which includes the past and present illnesses, examinations, tests, treatments, and outcomes. And let me just be very frank with you when I say that I understand that that's a lot. I have 3 girlfriends of mine who are very close to me who are nurse practitioners. One of them works in the private sector and another 2 work in a hospital setting. And they all have different specialties of practice, but one thing that they kind of all seem to have complaints about has to do with the kind of the time-consuming nature of the documentation and making sure that each of these elements is found in the documentation. But one thing that I make sure that I stress to them as their lawyer friend is that if you're not documenting these observations and you're not understanding a person's past and present medical history, then how is it that you can then provide adequate treatment for the person or predict what the outcomes might be in those instances? One thing that I can share with you is that I have, of these nurse practitioners that I have a relationship with, 2 of them utilize electronic medical records and one of them still utilizes paper-based records. One tip that I can tell you is that there seems to be an equal amount of frustration as it relates to the time-consuming nature of documentation for both sets of individuals. For the people who utilize the electronic medical records, there's generally going to be a learning curve associated with understanding how to utilize the medical record that your entity has chosen. So they're going through that process of learning it and learning how to document within that record. Then over time, some entities may decide for one reason or another to change the vendor of their medical record. So after you maybe learned how to document in one medical record and you continue to move forward in that process, once that medical record vendor has changed, now you kind of start over with learning how to document in that system. And for my girlfriend who uses paper-based records, they still have that. But one of the things that I tend to stress with them a lot has to do with the liability of not having accurate and complete records. It's very important when you're looking back at a case that you're able to identify how that person came to make that decision. And if you're not documenting a number of the elements that we're just talking about, that can cause some trouble for you down the line if there's any issues for a medical malpractice case or anything like that. And I'll talk a little bit further about that in just a minute. One of the critical things about this medical record documentation has to do with the physician evaluation. How could they possibly be able to evaluate how you're doing your job and how effectively you're doing their job if they don't have a complete set of records to look at and review? That's very important for that physician collaboration piece. But it's also essential for the continuity of care. And I know from having worked at the Department of Public Health, often you all are working with other healthcare providers to assess the needs of different patients. So those other providers may be asking you for copies of your records. You may be asking that other provider for copies of records. If the information in those medical records is not accurate and complete, that really can have a devastating or inappropriate effect on the continuity of care because people don't actually know all of the information that they need to know in order to make health care decisions. So that continuity of care part is really important. So we want to make sure that, especially for those doing paper-based records, you want to make sure that your handwriting is legible. You want to make sure that it's accurate and complete. I can tell you from personal experience in typing so much as a part of our jobs, especially for some of the younger staff members who, type for the most part. When you get ready to try to write something in a record, it's really easy to just kind of gloss over it, and you know what you said, but maybe other people may not know that. So I'll date you back to kind of like 3rd, 4th grade when they were teaching handwriting. It's really important for other people, especially in the medical setting, to be able to know exactly what it is that you have down on that paper, not what you meant, but what you actually are documenting in the record. So that piece is something that's really important, and I'm going to talk to you all a little bit further about that when we start talking about some of the case studies. So one of the things that I wanted to emphasize to you all has to do with malpractice. And nobody necessarily likes that word, but malpractice is the failure of a professional to exercise the degree of skill and learning commonly applied by the average, prudent, reputable member of the profession. So this is like, if we're talking about a nurse practitioner, it would be, what would the average well-educated nurse practitioner do? If we're talking about a registered nurse, what would a registered nurse in the same circumstance do in those situations? And whenever you're talking about malpractice, you also have to have a discussion about negligence. And because negligence is always going to be the predominant legal theory of malpractice liability. So it includes several things. One of the things that it will include is the failure to follow up. If you fail to follow up with the patient, a failure to refer a patient out to a specialist if there's a need to do that. Also, a failure to disclose necessary information to a patient. That's something that can get you in a good bit of trouble, as well as a failure to give necessary care. So as we're looking at malpractice, there are going to be 4 core elements that you're going to want to pay attention to. So in this case, the nurse practitioner owes the plaintiff a duty. And when you say that a nurse practitioner owes them a duty, this occurs whenever that patient presents themselves to that practice, whether or not it be a health department, a hospital, some urgent care facility. Whenever they present and they're asking for treatment and they're providing you information, you then take on a duty to, as you all know better than I, to do no harm to that patient. So that duty begins once they prevent and you begin the treatment process. They also, nurse practitioners' conduct must also fall below the standard of care. That's the second element. And by standard of care, that goes back to what would another nurse practitioner do in that instance? If it's a physician, what would a very similarly situated physician do in that instance? If you find that the average nurse practitioner would not have handled it that way, then an attorney would argue that they fell below the standard of care, which could get you, which could provide some pretty serious liability concerns in that vein. Also, the third core element is that the nurse practitioner's conduct actually caused the plaintiff's injury. This is what we consider to be a new or should have known standard, meaning that the nurse practitioner either knew that by their act or their omission, their failure to act, that it may have caused the plaintiff to be injured, or that they should have known, based on their education and on their experience, that it may cause some negative outcome for the plaintiff or the patient in that regard. And then finally, there has to be an injury. An injury has to be established in order for a medical malpractice case, for someone to bring that type of case. And I wanted to kind of give you a couple of tips as it relates to medical malpractice cases before we go further. One is that medical malpractice cases can be very, very expensive to bring. And one of the reasons that it's so expensive is it takes a lot of time for a plaintiff's attorney to investigate these types of actions. Also, generally, you're going to have to hire experts in order to be able to bring a medical malpractice case. And as you all may know even more than I, a physician's time, a nurse practitioner's time, and a registered nurse's time can be really expensive. So as you're paying for those people to be available for depositions or to document interrogatories or anything that may go into the trial process, that could be a really expensive endeavor. So what generally happens is once, I would say, a competent law firm decides that they're going to take a medical malpractice case, generally what has happened is not only have they talked with the patient about the case, but generally they're going to go through the process of gathering records, whether or not the attorney asks, like in this case it would be the health department, whether they request records from the attorney's office, or it could be that they send the patient themselves to ask for a copy of their own records. That could also be the situation, and they'll review those records to determine whether or not they have enough information to bring a medical malpractice case. For those of you who may not know, a lot of times these plaintiffs' attorneys who bring medical malpractice cases operate on a contingency fee basis, which means that they're not going to get any money out of the case unless they're able to recover money for that patient or for that plaintiff. So at the time that they're making this assessment, they're trying to figure in their head, what's the risk? And all of this then goes back to documentation, which is what makes this conversation so important. Because what you're going to generally find is that in a medical malpractice case, everything that they're looking at is in hindsight. I can tell you from my now being in private practice myself and with the attorneys that I know who do medical malpractice cases, generally this is going to be a year to 18 months from the injury that someone is finally deciding to go into an office and talk about bringing a medical malpractice case. I know from working with the health department that you all have a pretty unique set of patients. These are not always going to be patients that are compliant. They're not going to always be patients who are going to go to do referrals on their own and that kind of thing. So you want to make sure that you take a good amount of responsibility, and we'll talk about this again in a minute, with your follow-up on referrals and things like that, because when attorneys begin to look at these medical malpractice cases, they're going to be looking at the documents from that time. But based on the number of patients that I know that you all see, you can't possibly remember things that happened a year ago or 18 months ago. But if it's in your documentation, it can certainly help you to be able to recall certain things. I know from talking with some of my friends in healthcare, some of them will say, well, I thought about those things at the time that I made those decisions. Well, those of you all who have been here for a while will remember that we had a general counsel who I have a lot of love for and respect for, and his name was John R. Weibel. And one of the things that he used to say, and it used to tickle me at the time, and now I understand how important it is that he used to say, if it ain't wrote down, it didn't happen. Now, I know that may not necessarily be the most grammatical correct way to say that, but it's so true in that if it's not written down at the time that it happened, then what you're going to find is that you're going to find an attorney like myself or another competent attorney who's going to kind of eat away at why you are able to recall these things now, but you didn't think that they were important enough to put them in the record. So I just wanted to emphasize this importance of this medical record documentation. I want to talk a little bit to you about dissecting a medical malpractice case, and then we'll get into some case studies, because this may not be the most interesting part to you, but I think just to ensure that I'm being responsible in having this discussion, I wanted to talk with you all about how medical malpractice cases generally work. The first thing that's going to happen is that the client is going to present themselves to the attorney's office. Like I said, this is not something that's going to usually happen immediately after the injury. Sometimes, especially in cases where there may be some type of wrongful death action or anything like that, it may take a while for someone to establish themselves as the executor of the estate to even be able to get an individual's records. At other times, you'll have conflicts within that individual's family, or even for the patient trying to decide, do I really want to move forward with this action or don't I? So a lot of times this is going to be well over a year later when they present themselves to the attorney's office. At that point, there's a consultation period where you kind of listen to the individual's story, and you talk about maybe doing a contract at that time. And then the record gathering starts. This is the most important part of an investigation for an attorney. This is the point where they begin to request records as the attorney's office, or they may say, and most often they may say, hey, we don't necessarily want to tip the provider off to the fact that we may be bringing a malpractice action. How about you go into that doctor's office and ask for a copy of the records yourself? Now, I have not viewed, I'm not positive of whether or not y'all's record policy has changed since I left. It hasn't been very long ago, but I know one of the things that we used to emphasize in the Office of General Counsel is if you have any reason to believe that someone's asking for their records because they're trying to bring some type of litigation, please alert your attorney and let them know. They can always, they will always appreciate it if you will put them on notice, and so that they can get a copy of the records at the same time that that opposing counsel may be getting a copy. early so that they can review it and start talking with you about ways that they might be proactive if any litigation does come of it. So I did want to note that. After they receive copies of the records, what's generally going to happen is that they're going to start consulting with experts. And again, this is why the medical records are so important. If the case may be against a nurse practitioner, they're going to hire a nurse practitioner to act as an expert in that case to review what you have documented and see whether or not it rises to that standard of care that we discussed. The same is going to be true of a registered nurse or a physician or any other healthcare professional. They're going to look to someone who's similarly situated in the profession to have them review the records. Because though attorneys think we know it all, we really don't. So what happens is we actually hire experts to tell us whether or not that individual met the standard of care. And depending on the severity of the incident or the injury, sometimes what you'll see happen is that we enter into some type of pre-litigation, either settlement or mediation. So if an attorney feels strong enough that there were injuries, but they're not quite ready to actually file a lawsuit, sometimes what they'll try to do is try to resolve the case prior to litigation. So that's what we call pre-litigation, and saying, listen, hospital or healthcare entity or insurance company that's representing the doctor or the nurse practitioner, we feel that you did wrong. We won't drag you through court where all of this stuff becomes public record if you'll go ahead and resolve the case with us for a specific dollar amount. So that's generally how medical malpractice cases will work. If the case is filed, what you can look forward to are receiving interrogatories, which are lists of questions that you have to answer pretty much under oath. There's a penalty if you don't answer those questions correctly, and then also depositions. And the depositions are where you go with your lawyer, the other side has their lawyer, there's a court reporter there that's documenting everything. You swear that you're going to tell the truth before the deposition begins, and there's a pretty lengthy process. A lot of times these will last an entire day. Sometimes they can last several days in terms of that. So that's another reason why medical record documentation is so important, because even at those depositions, they're going to give you your copies of your records, and they're going to ask you why you wrote that, or they're going to ask you why you did not write something specifically. How is it that you can recall something 18 months later that you didn't actually write in the records? So again, during that deposition process, those records are going to be used, and the experts will be asked to testify on your records as well. So that's really important. And I can tell you from reading some medical records myself that I talked about this, but I want to emphasize it again. Please make it legible. I've had some people, sitting before me that say they're reading their own records and they're saying, "Oh, I'm sorry, I can't quite make this out." Well, if you can't make it out, then how can you expect another healthcare professional that might be using that information to make their own healthcare decisions? How could you be able to trust them to accurately assess that as well? And one of the jokes that me and some of my girlfriends have, and I don't mean to be in any way facetious in saying this, is that this whole business of treatment and medical records isn't kind of a tiddlywinks contest. For other professions like attorneys or engineers or anything like that, the decisions that we make in the moment don't affect, life or death or health of an individual, though we think, that we're pretty important to society and that kind of thing. The decisions that you all make based on the information that you have, it can have a very immediate and sometimes pretty drastic effect on that person's care and treatment. So it's really important as you're going through making these healthcare decisions that you're spelling out, exactly how it is that you're coming to make those decisions. One of my girlfriends was saying that, it can be really hard because sometimes and this is true, sometimes you have patients that are really non-compliant. And you have to call them several times and follow up. Sometimes I remember from being here at Public Health, sometimes you even have to write a certified letter to say, come on, I've been really trying to get in touch with you. I really need you to keep forward and that kind of thing. And I can understand, because I do respect nurse practitioners and registered nurses significantly in terms of a profession. There are certainly days where I'm sitting in my office where I'm thinking, gosh, I should have made a different decision in terms of my career. So I do know that that's really important. And sometimes you feel like, gosh, there are other things that I could be doing with my time as opposed to continuing to call this person or continuing to send letters to this person. But one of the things that I say to them is every time you do that and every time you document that, you're further insulating yourself from the liability if it comes up later that that person didn't do what they were supposed to do and a medical malpractice case arises from that. Because how could a jury of your peers find you at fault when they can see the number of times in the medical record that you really tried to make sure that this person was compliant? So I did want to note that for our records. Now I want to talk with you all about some of the case studies, and I'm just going to kind of read these off to you as best I can. They're pretty long, so there really wasn't a way to do it, to put these all in the slides, or we'll have like 1,000 slides. But the first one that I wanted to talk with you as it relates to case studies has to do with misdiagnosis. In this particular case, there was a nurse practitioner and a physician that missed signs of a stroke for an individual. This was a 56-year-old male. And let me also say, as it relates to these case studies that we're going to discuss, I know that some of these case studies are going to be from hospitals or other entities that are, clearly are not the Department of Public Health or their health departments. But I still want to share them with you because the example that they're giving or the point that they drive home is very similar to the things that you all are going to experience day to day within your work environment. So this 56-year-old guy, he comes in, he's having hypertension issues, he's diabetic. Some of his symptoms are going to be headache, dizziness, weakness, tingling in his left side, and problems picking up his left foot. So these are the concerns that he initially had. The family nurse practitioner that evaluated him found nothing suggestive of a TIA and ordered an electrocardiogram, prescribed aspirin to the individual, and told the patient to return in about a week. Twice during that patient's visit, that nurse practitioner did go and talk with the physician about the symptoms that that individual had, but the physician never did actually go and examine the patient at that time. The patient's symptoms worsened, and so he ended up going to the emergency room, which once he presented himself in the emergency room, they diagnosed him with having a stroke, with the signs and symptoms of a stroke, and they began treating him for a stroke. As those symptoms progressed, though, he began to have physical and cognitive disabilities. And so what happened is the patient then sued, claiming that a lot of the disabilities and impairments that he now has to do with the fact that they didn't diagnose his stroke early enough. And he feels that he would not have these limitations if it had been diagnosed sooner and they were able to start treating that incident earlier. And there was also an argument, and this is why the physician even got involved. The case was originally against the nurse practitioner, but they were also arguing that the physician, based on the symptoms that they saw, probably should have also gone and had some type of visit with the patient because the physician was on site. The defendant's counsel, so their attorneys, the nurse practitioner and the physician, their lawyers argued that the treatment and the evaluation were proper, and that earlier admission would not have actually changed that individual's outcomes. But I can tell you that in that particular case, it did end up getting settled out of court for $750,000. And that was against the nurse practitioner. There were some other defendants involved, which allowed that money amount to go up even greater. But that is an example of an issue of misdiagnosis that may have been caught. And so you want to make sure that you're doing, what you're supposed to be doing professionally, and that you're also documenting appropriately. The next case study that I want to talk to you about has to do with a failure to refer. And in this particular case study, it has several different elements. The failure to refer is an important one, but there was also a failure to properly evaluate and document. There was a failure to perform adequate and appropriate follow-up. And then finally, there was a failure to order appropriate treatment, in addition to the failure to refer the patient to a specialist. So let me talk to you a little bit about what happened in this case. With this one, the patient was a 49-year-old male that was experiencing bleeding during bowel movements. So the individual comes into the office, is seen by the nurse practitioner, and on that first appointment, he relayed the concerns, saying that, whenever he went to go ahead and have a bowel movement, that there was a lot of red in the stool, sometimes, a significant amount. It was bright red. Based on those issues, he also had some other issues, past medical history of depression, anxiety. He was a heavy user of alcohol. He had hypertension. He also had a significant family history of colon cancer and cardiac disease. The defendant, who was the nurse practitioner, performed a detailed physical assessment on the patient along with a digital rectal exam. The digital exam was negative for any tumors or tears, and so she ended up diagnosing the patient with internal hemorrhoids. She provided him a topical cream for that, and also some additional medication specific to that, and then she referred him out to further to have a colonoscopy and to further have him assessed. At that time that she was telling him, hey, I think you should go and see this other healthcare professional, he was very adamant with her then that he did not want to go see another healthcare professional, and he did not want to go and be examined by this other specialist. So he was given the suppositories and the hemorrhoid cream and scheduled to come back in about 3 weeks. When that individual came back after that 3-week period, he never mentioned any of these issues about the blood in the stool or anything like that. He did continue to have them, but he didn't mention them, and the nurse practitioner did not ask about it. So he saw her again another 11 times over the next 18 months with various complaints of other things that she certainly assisted him with. Then later, his wife, recognizing that he's still having these issues of pain and blood in his stool and that kind of thing, ended up contacting a specialist and having him go in to be seen. And when he went in, they discovered, and it was about 20 months after the initial exam that he went into the specialist, they did find that he had a 4-centimeter tumor in his rectum, and the patient was later diagnosed with differentiated metastatic colon adrenocarcinoma, if I'm pronouncing that correctly. Then, unfortunately, after that, the patient died about a year later a year after that cancer diagnosis, I'm sorry. And so what happened when this case was brought is that there were 8 experts that provided opinions during this case from various nurse practitioners and family medicine physicians that were critical to the nurse practitioner's handling of the case and saying that she didn't meet the standard of care in this case. The experts stated that the nurse practitioner failed to properly document and follow up with the patient's history of rectal pain and bleeding, thus allowing for the colon cancer to continue to progress. Several nurse practitioners provided expert opinions about how critical it was that nurse practitioner follow up and document about and have, complete documentation about this particular issue. And I can tell you in reading this case more thoroughly, and I won't read the rest of it to you, what the nurse practitioner said at the time that this case came up was that she felt that the patient was pretty embarrassed about having to be examined by a female. She could tell that that individual was really uncomfortable about that. He was uncomfortable discussing it with her. So when he came back for the follow-up and then came back about other issues that he was complaining about, since he didn't mention it, she decided that she also would not mention it. Another thing that was significant about the case is when she first told him that he needed to go and follow up and see a specialist, he said to her then, I don't want to do that. I'm not going to do that. Basically meaning that he wasn't going to be compliant. At that time, what that nurse practitioner should have done was document that discussion with him. Document the fact that she told him that he needed to see a specialist, and further document the fact that he was going to be non-compliant. What happened in this case is she remembered saying that at the time that this case came up, but they kind of ate her apart in the fact that how is it that you can remember here almost 2 years later after the case has been filed that, you know, you very specifically remember telling him that he needed to do these things and him saying that he didn't want to do it, but you didn't feel that that was important enough to document that in the medical record. So that became also a significant part of that case. So there are some lessons to take from this case. One of them is to obtain and review and consider pertinent patient medical history. Whenever you see that there's a history for that patient to have that colon cancer in his family, that kind of thing, that's a red flag to you. You got to make sure that you're following up on that. Also, document all patient-related discussions, because I can tell you whether or not it's convenient for them to remember or inconvenient for them to remember. The patient isn't going to say, oh, yeah, absolutely, they absolutely told me to do it, and I just refuse to do it on my own, and so I caused this to myself. That's not going to happen. So to protect yourself from liability, you want to make sure that you're documenting those things. You want to record all noncompliance at every turn. If there's a follow-up, you want to record any noncompliance there. If it's something that's a continuing issue, you want to continue to document that. And also, you want to make sure that you're informing the patient in writing. So if you've told, and I know this happens at our health departments where you've seen a patient, you've asked them to come back, they haven't come back. You've spent your very important time calling them, following up. Then you start writing them letters. Well, when you write them the letter, you should be saying to them, hey, you know, on this date, I've asked you to follow up with a specific specialist. It is my understanding that you have not done that yet. Please contact our office so that we can begin this process. So it makes it very difficult for an attorney to then say you didn't do what you're supposed to do when you have all of these layers where you're showing that you're doing everything that you can to assist this patient, and the patient themselves is just being non-compliant in that way. For our next case study, I hope I'm not talking too fast. Everybody good? Okay. For this next one, this has to do with medication errors, and this one is a little bit more complicated, but in looking at all the case studies that I could provide you about medication errors, I really wanted to share this one with you. Now, for other professionals, it'd probably be pretty boring to go over these kind of medication things, but as I was reading it, I was thinking, oh yeah, a nurse is going to get this completely. So I decided to share this one with you. This one relates to a 23-year-old young woman. And this person had no significant medical history at all. And she presented herself to the emergency room with flu-like symptoms. And what was happening is that as she was having these flu-like symptoms, she had tried some over-the-counter medications. None of them were working. And so, you know, her condition was getting worse and worse. And so she decided to go to the emergency room. So after she got to the emergency room, there was an abnormal CT scan of her chest. They noticed that there was elevated white blood. There was an elevated white blood count, abnormal liver function test, and an abnormal coagulation profile. The emergency department physician admitted the patient to the intensive care unit under the care of an attending physician. The patient started an oxygen and antibiotic therapy. Blood cultures were drawn, and it showed that she had streptococcus pneumonia, and antibiotics were appropriately adjusted per the recommendations of the infectious control specialist, infectious disease specialist. The attending physician first saw the patient while she was in the intensive care unit. And at the time of the initial exam, the patient had no significant respiratory distress type issues and was responding well to the oxygen and to the antibiotic therapy, and was subsequently continued on that same therapy. The attending physician noted that while the patient was not in acute distress, that her blood chemistry was abnormal with a potassium level of 2.9. The physician ordered 30 MEQ, which is, I think, milliequivalent is the way that's described, of potassium to be added to each bag of the patient's intravenous fluid infused at 80 milliliters per hour. The order was to be maintained through the remainder of her course of treatment. So 2 days later, and despite the potassium that's being added to her intravenous fluid, the patient's potassium level was still noted to be at about a 3.0, and the attending physician ordered 80 milliequivalent of potassium to be administered by mouth. Well, after this happened, then the patient threw up. They were unable to determine how much she was able to maintain versus how much was regurgitated. So the attending physician then ordered 2 doses of 40 milliequivalent of intravenous potassium to infuse over a 4-hour time period, with the plan of increasing the potassium level between 4 and 4.5. The documentation in this case was notably problematic. It appears that despite the order of 2 doses of potassium at 40 milliequivalent to be infused over a 4-hour period, the intensive care unit nurse administered 2 intravenous potassium doses of 20 milliequivalent over approximately a 1-hour period. The documentation regarding that, of the documentation that they found, a good bit of it was deemed to be inconclusive. Throughout the day, the intensive care unit nurse documented that the patient's heart rate, she documented the patient's heart rate in the medical record. And the findings after reviewing the record was that at 7:30 a.m., the individual had a heart rate of 72 beats per minute. At 1:30, it escalated to 96 beats per minute. And then at 4:30, it escalated to 116 beats per minute. But the blood pressure remained consistent at about a 120/80. The intensive care unit nurse did not go back and tell the physician that now this heart rate was now being elevated. So the physician had no knowledge that that occurred. When the physician saw the patient that day, he noted that the patient's white blood cell and platelet counts remained higher than normal, but were dropping. And in addition, her vital signs were within normal range, and she was not in respiratory distress. He ordered a pulmonary consult for possible bronchoscopy, but deemed that she was stable and that vasopressors and aggressive pulmonary treatment were not necessary at that time. He ordered the patient to be transferred to the telemetry unit, and this is where things kind of get significant. So the intensive care nurse's documentation failed to provide the exact time that the patient was transferred to the other unit. But even though it appears to be between 7:15 that day and 7:30 that day, so this is a big day. You got the escalating heart rate over the day that the physician isn't aware of, and then by 7:15, 7:30, she's put into another unit. The documentation also failed to validate that the intensive care nurse's statement that the patient was on a cardiac monitor during her intensive care stay, and that she was transferred to the telemetry unit with that cardiac monitor and oxygen therapy. So there began to be this dispute back and forth between that particular nurse and this new unit about whether or not they were informed that she had that monitor and whether or not that monitor actually went with that patient. Those nurses stated that they were really busy at the time of arrival. They didn't notice it, and there was nothing in the record that described that occurred. And regardless of that, there was no electrocardiogram strips with the patient or when the patient was transferred. So according to the hospital records, and again, we're going back to the records, the attending physician was called at approximately 10 p.m. that day and was advised that the patient was undergoing cardiac arrest. The on-call emergency physician attempted to resuscitate the patient. That attempt was unsuccessful, and the patient was then later pronounced dead. The family of the decedent sued. So this is going to be a wrongful death action. And so after the family has contemplated what happened, someone has been put over their state. Again, you got to see time is passing now. Then they decide that they want to bring litigation. They decided that they were going to sue the hospital, they were going to sue the physicians, and they were going to sue the nurses for approximately $3 million for that. The allegations against the intensive care nurse included alleged failure to properly administer the medication as ordered by the physician, and a failure to notify the attending physician of significant changes in the patient's vital signs or laboratory results. Initially, the defense team felt that they had a really strong case for that particular intensive care nurse because because that nurse felt really strongly that she'd done, what she needed to do to care for the patient. But what ended up happening is they ended up getting an expert, someone who's very similarly situated to her, to go and review the records. And in reviewing the records, that's where they saw the discrepancy of the medication error. That's where that came up. Then all of these other things began to unfold about not having complete documentation of the monitor going to the next level, of the time of transfer, and all of these things occurring. And it was also really significant that as that patient's illness progressed, or that there were significant changes with them, that she wasn't informing the physician of this. Because sometimes I think what happens is nurses, I know for clients that I have, the nurses kind of think that the liability is going to fall on the doctor, so it's kind of like, hey, I'm going to do the best that I can, and then if something happens and it all shakes out, it's not, necessarily my responsibility. But because of that physician collaboration piece, but that's not always the case, I can tell you. A lot of times what plaintiffs' lawyers are going to do, including myself, is that when we get a case, we're going to sue everybody who we think might be involved in that case. So that's going to go for the nurses, that's going to go for the physicians. If it's a hospital, it's going to be them. If it's the health department, it's going to be you all as an entity. And so then, as you see documentation that shows that maybe that person wasn't as liable as I thought that they were. For instance, in this case, it might be the physician, because that person, was acting appropriately. Then you begin to what we call dismiss. Their attorneys will file a motion to dismiss them, saying, hey, it's not enough evidence to show that we did anything wrong. And then the plaintiff's lawyers will start to dismiss individuals out of the case. So it's possible for a nurse practitioner and the entity, or a registered nurse, to still be involved in a lawsuit, even when other parties, like physicians or others, are actually out of it. Typically what I'll see is that the hospital, or whatever the entity is, I don't care if it's an urgent care, I don't care if it's the health department, they'll generally stay in, because they're the ones with the policies and the procedures that that nurse practitioner is supposed to be following. And if there's any issues as it relates to those policies, it'll generally fall back on that entity for that. So let me tell you how it ended up shaking out. After that expert witness stated that the intensive care nurse's care and treatment of the patient was not medically defensible, meaning that it fell below the standard of care, the claim against that particular nurse was for $100,000. And then there was about a little over $6,000 in legal fees that were paid out. And then between the hospital and others that were also sued, it ended up being about a $1.4 million settlement. So as you can see, everybody's playing a part in this. It's up to everybody to ensure that, hey, and even you all, if you see policies and procedures that need to be updated, or changed, suggest that to your supervisors, because everybody's going to play a part in ensuring that you're providing appropriate care for these patients. And if that's not being done, there are certainly some firms out there that are going to suggest that changes be made to these policies and procedures. And I don't know about you guys, I certainly prefer to make those changes to policies and procedures myself, as opposed to having some type of verdict or a settlement that influences me to make those changes. And I do want to apologize, because this was my error. I actually made an error in the word error on that case study slide, so I wanted to apologize for that. Then we have this next case study that I want to share with you, which has to do with the failure to perform routine screening. And so in this case, there was a child who was visiting a primary care center, and the child visited that center from the time sometime after birth until about 9 months. And we don't necessarily know the age of the patient during these initial visits, because it wasn't documented in the record, which is just part of the issue. But what happened is that the mother pointed out to the nurse practitioner that one of the child's pupils seemed like it was larger than the other one. And as mothers, and I don't want to be sexist, fathers too, you notice these things in your kids, and we don't generally, y'all are healthcare professionals. For the rest of us, we don't understand. The only thing we have is Google. So we don't know how these things work or what should be done, and we have to be really vigilant in letting you all know when there are issues. So there's only so much that WebMD can do online. So she tells the nurse practitioner, hey, I think there might be an issue, with one of the pupils being larger than the other. The nurse practitioner dismisses that. Then 2 months later, that same parent parent is back with a nurse practitioner, and she's saying that the kids' eyes didn't move in tandem with each other, and she was kind of concerned about that. So the parent claimed that the nurse practitioners said that those symptoms weren't important. So then 3 months after that, the nurse practitioner then, when it's called to her attention again, then tests the child for red reflex. The nurse practitioner saw no light reflected back and referred the child to an ophthalmologist who diagnosed retinoblastoma in both eyes. One eye was removed from that child 3 months later, and then the other eye had to be removed 3 years later. Obviously, it had a very devastating impact on the patient and for the mother. And the mother did agree in this case that she knew that they couldn't save both eyes. One eye was probably so far past being able to save it when she began to make these notes to the nurse practitioner. But the argument was if she had done what she should have done at that time, it's possible that they may have been able to save one of the eyes. And so the mother made that admission. I can tell you that the parties ended up settling that case for $2 million afterwards. So that failure to do routine screening is really important. Now, that may not be what is being done at the health department in terms of routine screening. But take that as a lesson in when attorneys see these types of cases, regardless of what they are, they're going to start asking around of what should have been done. Regardless of what the healthcare issue is, they're going to start asking, well, what would you have done? What kind of tests would you have run? What other type of screening would you have done? And if they find that that this person violated the standard of care and didn't do as other similarly situated groups would have done, there could certainly be liability there, and that's when you get into these settlements and large verdicts. So understanding the standard of care for routine screening for your population is important. I don't pretend to know. As you see, there are words that I can't even describe as it relates to y'all's work, but you know well the types of things that you see on a regular basis and what you need to do to address those specific issues. So make sure that you're doing that and you're performing those routine screenings, and in addition to that, make sure you're documenting it. Because like the great John Weibel said, if it ain't wrote down, then it didn't happen. This next slide talks about reducing your risk of being involved in a medical malpractice case. As I've said over and over again throughout the course of this discussion, I'm sure you all are probably sick about it now and won't be inviting me back, but appropriate documentation is really important because that's all we have to go on. Like I said, everything is hindsight when it gets to be, when it comes down to a lawsuit. The only thing that you're really doing is reviewing records. If we're finding that you're remembering something 18 months later that you didn't feel important enough to document, that's something that's going to weigh heavily on a jury when they're listening to these issues and saying, well, it's sure convenient that you're able to remember these things now, but they weren't important enough for you to document at the time that it happened. In terms of communicating with lawyers, I wanted to make a distinction. Because I did have the honor and privilege of working here, I do understand how important it is that you know the distinction between the communications that you may have with your lawyer as opposed to the communications that you may have with an opposing counsel. If ever you think that there's some type of issue, maybe a patient goes as far as to threaten a lawsuit based on something that's happening in the clinic setting or something that you're aware of, you want to bring this to your attorney's attention, and you want to be really honest and upfront about everything that may have happened throughout the course of that visit or several visits with your lawyer. You don't want them to have to pull teeth and try to figure out what happened, because lawyers are almost experts at trying to understand a number of different things, but there's no way that we're going to have the educational background and understanding that you're going to have about your specific area of expertise. So there are going to be things that a lawyer doesn't even really know to ask. So it's really important that you say, hey, when they came in, they presented with this, and this is what this means. And really educate your lawyer about that process and why it is that you made the decisions that you made. Another thing that's really important with your lawyer is your lawyer is yours. There's going to be, there's a certain level of expectation with the State Bar and with other groups, that you're able to be really honest and candid with your lawyer in a confidential manner, that lawyer is not going to go out and repeat those issues later. So if there's something that you're concerned about, you need to let your lawyer know, hey, maybe I could have done this differently. You want to make sure that you're very upfront with them, because it's kind of like something that my mom used to say when we were growing up. I can't protect you if you don't help me. You have to be honest with me so that I know if somebody calls. My mom used to tell this joke all the time. She used to say, hey, look, if you go out and kill a bunch of people, I'm still on your side, but I need to know what happened. I need to know what's going on so that I can help you. And it's the same case, with your lawyers. Whether or not there was an act or omission that you had that is concerning, be really honest with them about what's happened. I can tell you, I know a lot of the lawyers in y'all's office. They went to really great law schools. They have really good understandings of cases, and most often what they'll do is they'll even bring in another law firm that is really keen at defending these types of cases. And they can't explain the issues to that other firm unless you've explained the issues to them appropriately. But then also for opposing counsel, you don't treat opposing counsel in the same way that you're going to be treating your own lawyer. And the reason that I mention that is you may think, wow, there may a patient threatened me and said that they were going to file a lawsuit against me. And then maybe they even asked for a copy of their records. But the next thing you know, an attorney's office might call you, or maybe even like a paralegal or somebody from their office may call you, starting to ask you questions about this case. It's important to know that before you ever have any conversations with someone who might be opposing counsel, you need to let your lawyers know that this person is reaching out to you, that they're contacting you, that they may be asking you questions, and your lawyer can prepare you, either let you know if you should be answering the questions, and if you are going to answer the questions, then they'll be able to adequately prepare you as to how you answer that individual's questions. Because I can tell you, you answer questions honestly all the time. You have to answer the questions honestly. But there's a certain level of detail that you may provide based on questions that your lawyer asks and another lawyer. Generally, we joke that it's kind of like pulling teeth. Like, you answer the question that they give you and only that. Whereas with your lawyer, if they ask something and you think that they didn't catch on to something, you're trying to think, well, let me make sure that I explain this so that they have, the entire story. And I know that may seem kind of funny to you guys. I promise you that's just the way things work. You're better off if you go ahead and take those tips to heart. Some tips for handling high-risk patients. I absolutely understand, again, from working here, that a lot of these patients, it's almost like a revolving door. Sometimes these patients are brand new. Other times they're going to be patients that you've seen year after year, and it's kind of always a different story. Like when you're working, from my understanding when I was here, for those of us who work in the health department, every day is a different day. It's really, really unpredictable, so you really don't know what you're going to get. So I thought that it might be helpful if I kind of talk with you on the front end about some expectations that you might have and ways that you might go about handling patients that might be considered to be difficult, or what we might consider to be high-risk patients. One patient that would be a high-risk patient, and from my vantage point, is a patient that has low intelligence. And there's absolutely nothing wrong with that. I'm not saying in any way that person is a bad person in any way. But when you have someone who may not have the highest IQ, or that you think that when you explain things to them about their health conditions that they may not necessarily be taking it in, it's really important for you to go a few steps further in how you converse with that person. Again, documentation on the things that you say to them are going to be extremely important. Sometimes you may even ask that individual to bring a person with them, whether it's their mom, whether it's a spouse, that may come in to also hear the things that you're sharing with them. Sometimes what you may even ask is for a coworker to come in, someone who's also working at the health department, to have a witness that you're saying these things to this particular individual, because you may not be totally positive that this person is engaged enough to understand what it is that you're talking about. And whenever you can put something in writing to that person, that's also good. If you can follow up with a letter to someone like that, it's certainly good to have that proof later on if some issues come up. Polypharmacy, this is when a patient has like multiple medications. And this happens, I know it's a big issue that's trending globally, and it's become something that we've been talking about in our country a lot, is, the opioid epidemic and other medication issues where people are seeking, where people are on several different types of medications. When these things happen, you want to make sure that you have a good understanding of the types of medications that that person is already taking. And you can't be, and we don't expect for you to know that person's background with that person not telling you. The only thing that you can know is what they share with you and what's already in the record. But, if I were in your shoes, I'd want to, clearly document what that patient told me in terms of the medications that they're already taking, so that if for some reason a different medication was prescribed and it didn't work well with that medication, you've got some, well, let me say this, if that patient is taking a medication that they did not tell you about, and the medication that you prescribed to them becomes problematic, you have something to show, hey, they omitted that. I don't know why they omitted that, but I can show you I already knew what medications they were taking because I documented it, and that's not one of the ones that they stated. So that would be, those individuals are considered high risk. Non-compliant patients, like we talked about in the case study, they're a really high risk. That gets back to, and I know, because, as a professional myself, I know, specifically with the nurse practitioners and the RNs, they're probably thinking, I didn't go to school for this, to continue to make these phone calls, continue to send these letters and all that kind of stuff. You're probably thinking, somebody else might be able to sit behind a desk and carry this out. But I'm telling you, what I tell my friends is, hey, I want to insulate myself from liability. So if I have to make that phone call and write it down that I called them on that date at that time, and that I continue to do it and I continue to write that letter, hey, that's what I need to get by and to be able to get out of that lawsuit if something comes up. So those non-compliant patients, they're also considered to be high-risk patients because, like I said before, they're not going to ever say, yes, I know I should have done that and I caused it for myself, so maybe I shouldn't file this lawsuit. They're going to be looking at the part that other people may have played in their healthcare condition, and trying to figure out how they might be able to recover from those other individuals. I'm sorry, that's my alarm. I'm sorry, we would have otherwise been done, so I apologize. Another issue has to do with substance abuse, which I touched on just a minute ago, with people with medications and things like that. You always want to be on the lookout for people who are kind of wanting to self-prescribe. They come in and they're already telling you. Now, not your WebMD Google people. I think I've pretty much figured out what my condition is. But for these people who are kind of aggressively wanting to have specific medications, those are people that you kind of want to have a red flag for, and make sure that you're documenting that these people are asking, for these specific things. You never know if another nurse practitioner, I know for a number of the nurses at Public Health, I know from when I was there, you go from county to county, and you can't necessarily guarantee that you're going to be the nurse that picks up that file the very next time that person comes in. So it is really important that anybody who picks up that file has a good understanding of the history of what this patient might have been asking for, or anything like that. So especially like with these substance abuse types issues, you want to make sure that that is documented. And then finally, you have these people who are just outwardly litigious, for no other reason than to be litigious. Often you're going to find that these are the people that talk about having sued other providers while they're while they're under your care, or talk about how, hey, if you don't do this, or if you don't give me that, or if you don't schedule it this so, then I'm going to sue you. These litigious type people, you want to make sure that you're on the lookout for. And if you really do believe that it's an instance where they're going to maybe file a lawsuit eventually, like I said, you want to make sure that you're notifying your attorney of the fact that this may be something that comes up. Patient confidentiality, and I'm sorry, can you tell me about how much time we still have left?
We're working right now to extend the satellite time, so we'll know in just a couple minutes if we can.
Okay. Okay, I'll just continue till they stop me. One of the things that I wanted to talk to y'all about is patient confidentiality. Even though people may be thinking, oh, it's just because she was the privacy officer and she really likes HIPAA and all that, and I do really like HIPAA. I wanted to bring this to your attention because it's something that in my practice is a trending issue among all healthcare professionals, and this issue of confidentiality. And what I find is these professionals, whether or not they're nurses, social workers, nurse practitioners, physicians, they are not individuals who sit down and decide, wow, I can't believe that person has, chlamydia. I can't wait to get home and tell somebody about it. They don't make conscious decisions to disclose someone's information inappropriately. What I find to be happening is that there's an emotional component to it. You're in an argument with somebody. There's a fight about it. Maybe, you have a particular person at a medical office that knows of a patient's condition. They're going out, to a club, one night, and they get in an argument. One set of girlfriends gets in an argument with another set of girlfriends, and then there's some kind of Facebook argument that comes afterwards. These are individuals who, if they really stopped and thought about it, they probably wouldn't disclose somebody's information inappropriately. But in the heat of the moment and in that tit-for-tat emotion is where I'm finding that these issues are coming out. Generally, what is said, and it is in fact true, you don't go into state court for a federal regulation. So generally, nobody's going into state court in Alabama to sue specifically under HIPAA. So what attorneys in Alabama are doing, and I think it's really, really smart, is that they're suing under state statutes for things related to mental health, because there's a specific statute about the confidentiality of mental health records. There's a specific statute about STD records. We know that those things can't, that you can't further disclose those things. And they're using those state statutes to go into state court and sue for these breaches of confidentiality in terms of diagnoses and things like that. It used to be the case that the patients were so embarrassed about their mental health condition or their STD that even though their rights were violated and their information may have been shared, they didn't want to go into court about it because they knew that that case would become part of public record and anybody going into the courthouse might be able to go look up that complaint. Well, what they've gotten smart in doing is making sure that they file those cases under seal. And that means that the only person that has access to that complaint or answer or anything related to that case is the clerk of the court. So you don't have other people that are able to come in and see it. And because of that, I think people are more likely to come forward. Once their attorneys explain to them that they can file it under seal, they're more likely to come forward. The most successful way that I've seen this done is that the very first time that the entity becomes aware of the issue, meaning whether it's a health department, a hospital, even in some cases nursing homes, any healthcare provider, what happens is that the plaintiff's attorney will draft a complaint and they'll also draft a press release. And so when the hospital administrator receives a copy of a draft complaint and a press release that may go out, being very specific about their entity and either things that entity did or didn't do, they get pretty quick to come to the table to talk about how they may be able to monetarily settle that case without it getting into the public eye or without an actual case being filed. So I did want to bring your attention to those trending issues because when you're talking about malpractice or anything like that, those confidentiality concerns are also important. So that's the end of my presentation. Do y'all have any questions?
I know there are a couple questions here in the room, so we'll go ahead and start with those. But just a reminder that you can call in or email us with any questions you might have.
I do, Samaria. Again, thank you for a well-rounded, comprehensive presentation. The common theme and the title of your presentation, Show Me the Records, speaks to documentation, of course. And I wondered if you could just talk a bit about what you do not want to document in the chart.
Right.
For example, you definitely do not want to out a colleague in the chart or to have a discourse back and forth. Can you talk a little bit about about that?
I can, and I'm glad you brought the title up again, the Show Me the Records. It's kind of a play off the Jerry Maguire Show Me the Money, and in a way they can go hand in hand. And so what happens is, in terms of the things that you don't want to document, it could actually come back to bite you if you're having these additional documentation about conflicts or things that you think that the other employee may not have done well. What will happen is if I get some documents like that and I see that there may be a conflict between individuals that are working in a specific office, you're going to, as an attorney, you use that to your advantage. So you say, okay, so then you start to play those two against each other, which could be hurtful for both groups. The medical record is not a place to address conflict. The supervisor is an appropriate individual to go to if there is any type of conflict like that. I think that for the most part, once you get to being a registered nurse, which you have to go do a lot of schooling for that, and a nurse practitioner and a physician, I think it's pretty clear to you, what needs to be in the medical record and what doesn't. And the slide that we looked at before about medical record documentation speaks pretty clearly to what needs to be in the record. Those outside things, they do nothing but confuse the case. And like I said, if there are any issues, those are things that need to be addressed, maybe from a personnel standpoint or with a supervisor. But you may think it serves you well, to out another patient within a medical record. But what you'll find is that sometimes that information can actually be used against you. Because one of the things that I can think of that I've seen happen before is when a lawsuit is filed, really the people in the entity want to band together. And they want to say, oh, no, I know my colleague, and I know that she's good, and I know that she's honest, and then when I look back at the record, I'll say, well, on November the 9th, 2008, you said, that she wasn't competent, or, that you didn't think that she was following the rules. So there really is no place in the medical record for those types of conversations.
Can I ask a question? Yeah. Samaria, thank you so much. That was a wonderful presentation. It hit a lot of points of some concerns that the nurse practitioners have vented with us at the Family Health Services Central Office staff. But if I am a nurse practitioner and I refer a patient, out for a problem that needs follow-up, we have been here of late trying to just bring about the point that is our responsibility. Will you speak as to how the legal side of the world looks upon that if I refer a patient out for a needed, maybe it's a breast mass or maybe it's a cervical lesion, as far as follow-up goes, where does that responsibility legally, how do you see that? Where does that responsibility, who does that responsibility fall to?
It's my understanding that responsibility lies with the individual that's making the referral. So let me just give you an example. Let's say I'm at one of the county health departments and I'm an RN or a nurse practitioner, just as an example. And I find that, I referred someone out, maybe they haven't come back in with me, maybe they missed an appointment, or that they're not, as far as I know, they have not going to the specialist that I asked them to go to. It's on that person who made the referral to actually follow up. But I'm going to tell you why you want to do that. If it were me, I wouldn't necessarily want to trust any other individual, whether or not it be a clerk, at the health department or some other clerical staff member to do that, because it's so important that it be done. It's almost a thing that is so significant that you almost want to do it yourself just to make sure that it's done appropriately. One joke that I can use is when my kids go to the doctor, I don't send my husband with them because I know he's not going to tell me what the doctor said and he may not relay the issues appropriately. So kind of a play on that is if you're the one that's reaching out to the patient, then you're in a position to answer their questions. If they answer the phone, then you can answer the questions that you have. It's not like the person has to say, oh, well, I'll get that person to call you back, and then this, this additional journey. But here's another thing. When you look at lawsuits and healthcare professionals nationally, what you find is that a lot of times patients are saying, well, wow, I didn't sue the nurse, or I tried to, delay or talk my lawyer into, and I have a case like this now, where they say, well, the nurse was so nice, and they really tried with me. Can I sue the hospital without suing the nurse. There's a relationship that develops between a nurse and a patient that, no offense to the physician, but they don't have as much interaction. And so what you'll find is regular human beings who find that someone has really tried to follow up with them and try to do what they could to make sure that their health was taken care of appropriately, they have a harder time going against that individual when they know that that individual tried. Same thing with a jury. Let's say that the patient gets over that hump and says, hey, I just want to sue everybody anyway. You put 12 people in a box and you can show where that particular nurse reached out to the patient on their own and followed up, then it looks like, wow, this nurse really did do whatever they were supposed to do. They didn't push that off to somebody else who may or may not do it. And they tend to have a lot more sympathy towards that individual.
We have one question that's just come in on email. We need to answer pretty quickly.
Okay.
Though. So the question is from Amy, and she says, thank you so much for providing the webinar, Show Me the Record. Can you provide the contact this is just a contact information thing. Yeah, we'll provide your contact information. The contact information is on the slideshow, which is on the website. So we will be able to provide the contact information that way. So someone could be able to reach out to you in that way. So, or you're accepting of emails and phone calls.
Absolutely. Yeah, we still don't bite. So yeah, we'll be happy to answer any questions that anybody has.
Okay, I apologize for not previewing that question
it's
before. I
fine.
wanted to be able to get it in quickly. We're going to go ahead and close the presentation now. Thank you so much, Samaria, for joining us. We really appreciate it. And thank you so much for watching. We have been getting some questions from folks about sign-in sheets and things like that. So you'll be able to watch this program on demand, and the sign-in evaluation sheet will be on available the website later today. So you can go to alabamapublichealth.gov/ALPHTN. Thanks so much.